We got 24 people in here, and I think it's such a popular question. So we can definitely revisit that. Hey everybody, thank you so much for joining. We have Mick Hughes here. Thank you so much for coming on, Mick. I know it is super early down in Australia, but Mick and I, we've been talking for probably a half hour now. We're just chatting sort of how ACL recovery and rehab is there versus here. I'm just picking his brain because Mick he's a super smart guy and he's super passionate about ACL rehab. So we were just talking about revascularization, sort of how to interpret it, what to do about it, because we hear about it in articles. And I think Mick brought up an awesome point. And then we'll definitely revisit that question because that was awesome. Thanks for sharing.
Yeah, no worries. And thanks everyone for joining in, the 25 of us that have joined in so far. Thanks for coming in for the chat. I'm into my second coffee. It's 5 a.m. here in Australia, so nice appropriate time for you guys up in America. I hope you're enjoying your lunch break and so there's some sunshine out there. Here it's a bit colder in little old Melbourne. I think it's about maximum of 13 or 14 degrees Celsius here today, so it's going to be a cold one.
Awesome. And then Mick, I didn't tell you, but I created a poll. How would you identify yourself? And the results are starting to come in. So if you click on that poll button, you'll see it. But it sounds like over half the people here are PTs. We have some ATs, some students, some athletes. And then this will tailor our questions, as well as when we open up the floor to a live Q&A, we'll have a better idea of who our audience is and how to tailor our language.
Yeah, great. I've got probably, as much as I'd love to, and I guess as the conversation rolls on, I've got probably probably got about an hour maximum before my kids start getting up and I have to start doing daddy duties. But, if I don't get any questions answered today, I'll certainly happily reply to emails, and I'll leave my email with you guys. I'm doing a Facebook Live tonight, Australian time, where we're talking a lot of return to sport criteria from my Facebook page. So if you don't get the questions that you'd like to be answered, they've probably already been answered before on some of my previous Facebook Lives, but they also might be discussed tonight as well. So yeah, as much as I'd like to try and answer everything today, we'll do our best.
Yeah, for sure. So Mick, why don't you go ahead? You can type in your email so that people have it. I'll just do you a favor. I'll type in your Instagram handle so that people know it. I have a feeling that most people know it. But that's Mick.
Where can I type in my email?
So if you click right above that little button for the poll where the chat is, you should be able to type to everybody. If not,
cool. Yeah.
Awesome.
Yep.
And then after you type your email, we'll jump right into some of the questions. So Mick sort of touched on it. We're going to try to cover some questions that we lined up within probably 40 minutes. And then the rest of the time, we're going to open up to the Q&A to everyone that's in the room. So if you have a burning question and you're nervous that you're going to forget it, feel free to type it as we go, because I know that I can have a scatterbrain as well. So if you need to write it down, go for it, type it in. Otherwise, we're going to hold from trying to answer every single person's question until the end, just so that we can get through our questions, and maybe our questions that we have lined up may answer your question. So let's jump right into it. So the first part, I'm just going to sort of ask Mick some questions. He has at least one question for me at the end. And then, like I said, we'll sort of open up the floor. All right, Mick. So is there any benefit to pre-op physio?
Yeah, it's in a short answer, absolutely. There is. We were just discussing off air how clinically, in our own experiences, we've seen how important the pre-op phase can be for some people. We'll just quickly discuss my case that I've seen and then discuss the literature around it. But I've seen two people I can think of in the last month. A guy that turned up post-operatively at the 4-week mark, had injured his knee, had not done a lick of exercise before the operation, had the operation, turned up, and his knee really struggled, and it continued to struggle for the next 3 months. It wasn't bending as well as what it could. His strength was slow to return, and he was just struggling compared to most of the other people that I see. And then compare that to another guy that I saw, preoperatively for a good 3 months, and actually got him back to the point where I was trying to sort of talk him out of operation because he was hopping and jumping and landing and running and sprinting and cutting and changing direction without an ACL. And he was looking really sharp, but he was so headstrong and so confident that he wanted to have the reconstruction. So he had the reconstruction and was flying through rehab and ticking all the criteria and killing it at the 3 month mark and back to running at 3 months and doing really well. So they're my experiences with it, but also too, the research will back that up as well. So there's probably three reasons, three particular points why pre-op physio is really, really important. And the first and foremost is one research in particular will show you that if you can get higher subjective questionnaire, so the KOOS, the KOOS, there was a nice study done a few years ago that if you had higher KOOS scores leading into the operation, you had much better quality of life and better function up to 6 years down the track as well. So it's not all about getting back to sport quicker and all that kind of stuff. It's your quality of life, many years after the fact that you've gone through rehab. In saying that also too, if you have higher KOOS scores and higher strength levels leading into operation, you're also more likely to go back to your pre-injury level of sport as well if you do a block of really good pre-operative physio. And that's been shown in a recent study where they compared the Moon cohort, which you guys might be familiar with in the study. It's an American-based multi-center ACL register compared to the Delaware Oslo cohort in Delaware and obviously in Norway. Now that DOC cohort do 10 extra sessions of pre-op perturbation training and neuromuscular training before the operation. They found that group were returning back to sport in high numbers within 2 years compared to the Moon cohort as well. So that was pretty cool research published in the last 2 years. What the pre-op time can also do for you, you can actually capture some really nice baseline data for your athlete that you can use at a later date. Now, this is pretty cool stuff. So you might be familiar, Craig, with there's a study by Wellsant from 2017. They looked at estimated pre-injury capacity, and they called it EPIC, and they compared it against the limb symmetry index, which we typically use. And so this EPIC criteria, basically they capture strength and hop test numbers out of the unoperated leg, and they use that as a comparison at the 6 month post-op mark, 9 month post-op mark. And they found that when you use that EPIC criteria instead of the limb symmetry index, it was more sensitive to detect second ACL injuries down the track. So working clinically, sometimes you don't have the beauty of having a whole lot of pre-season testing, unless you're working with athletes and you're working in that sporting environment where you do a lot of pre-season testing and you know how fast people are, you know how far they can jump and hop and all those kind of things. If you're like me that work in the clinical world and you don't get to see people until they have an injury or they have an operation, you don't know what their previous best is. So the best we can often do is just capture their current best before the operation. And that current best is often their uninjured side that you should be comparing against at a later date. So pre-op physio, it's a must. And if we're not encouraging people into it, then we're probably doing our patients a disservice.
Yeah.
What experiences with it, Craig?
What's that?
What's your experiences with it? Have you've seen it clinically as well?
It's day and night difference. When I get to see people that do ACL prehab, pre-op prehab, and then people that I see, 4 or 6 weeks after surgery, they didn't do anything. It's just day and night difference. Posted a video yesterday. It's still available on the story. This is someone that did pre-op prehab with me, and then 12 weeks was this week, and he crushed running. Not even like a stiff knee landing. Granted, like he was fatigued, lacked endurance, but on video, like compared to some other ACL patients that I've seen, his active shock absorption and the knee stiffness with landing, it was not that bad at all. Versus I had people that are 4 months, 5 months ACL rehab. They didn't do any prehab, and they are nowhere near close to running. It's day and night difference. So I think you bring up great points. I love that one exercise program that the Delaware cohort cites. So it's like 5 or 10 sessions, right? No, it's 2 sessions.
10, yeah. 2 sessions a week. 2 sessions a week over 5 weeks.
Yeah. And you can access that for free. What I'll do is I'll try to find it. I think I have it on my laptop. But that is like foolproof, really nice, easy following program to use. And anyone who's physio or, I have a couple clients who just getting an ACL reconstruction surgery right now does not make sense in their life. So following that program made like incredible changes in their life as well as their rehab, and people have been able to delay. Like just one kid was getting ready to graduate from college, and he's like, "Dude, I just can't get surgery right now. This doesn't make sense. I want to walk at graduation." We followed that program, and after 4 weeks, he was like, "I'm good." So, yeah. I mean, ACL prehab is a must. It's an absolute must.
And that's the cool stuff that we're saying. If we do that high quality rehab, we can almost get to a point where people can go for as long. People should be then thinking about going for as long as they can without an operation. And there's and this is probably taking a bit of a U-turn off our topic of conversation being how can we better better rehab reconstructive patients, because the non-operative management's another 2-hour talk in itself. But there's also a whole separate group out there. There's a group of people who can cope without an ACL, and they can do so very, very well without one. We just don't know confidently who those people are, and how long they'll last for without who in terms of coping. We don't know how long they'll last, and it's basically a toss of the coin. 2 people will walk in. One of them will be coping 10 years down the track still without their ACL. The other one will probably not cope anymore within 6 months. We just don't know very well yet. But every person should be given that opportunity. That's sort of my opinion on it. I guess it becomes very grey when you've got an elite athlete who's got very, very defined time points where they want to go back to sport and they're getting paid to go back to sport. That's where a club they don't want to hear that this person could be back in 2 months and then fail again. They want to know that this patient would be ready in 9 months and ready to go.
Yeah, I think one of those articles about copers that you sort of shared some information on in some of your online lectures. In one of those same articles, it points out that like 20 to 30% of people opt for ACL rehab just because they think it's the norm. They've been told to do it, so they just do it. Yeah. So it's really interesting. When it comes to copers, I always think in my head like proceed with caution, just about like what you're educating people on, what they're going to go back and tell a surgeon. I think like proceed with caution, but yeah, I mean, I think within the next decade, we're going to learn a lot more about people coping and identifying who those individuals are. Cool. So before we go down that rabbit hole, let's go on to the next question. Unless you had any other closing thoughts on that, Nick. Sorry to cut you off.
No, I think we'd probably take our talk up to about 4 hours if we kept on going down the non-operative path. So we'll save that for another day.
All right, graft types. Doesn't matter. Also, have you seen quad tendon with ACL or ACL repairs? Share your experience.
Yeah, look, I think graft types they matter. For the simple reason, if you're having a first ACL reconstruction, I think a graft type matters. And when I'm talking graft types, what matters most is that it's your own tissue. I don't think we should be electing for cadaver tissue or synthetic tissue for the first, so a Lars ligament for your first ACL reconstruction. That's what matters. And the research will back that up. If it's your own tissue, it's more likely to survive and not fail. But those that have cadavers or synthetic tissues often fail in higher numbers than those that have the hamstring graft or a patella tendon or a quad tendon. That's what really, really matters. In terms of the 3, hamstring, quads, patella, they all fail at the same rate, okay? So I think graft doesn't matter if it's your own tissue. What matters most is your high quality rehab to support that graft, because if a bone patella bone versus a hamstring, the outcomes are going to be the same. But what's going to make that graft stick the most and survive the longest is going to be that high quality rehab that you put in. So that's what matters the most. If you had second, third, fourth, fifth, and sixth ACL injuries, by all means, you've only got cadaver tissue left and a Lars ligament left, or what other tissue you can find, then go for those other grafts. But for your first ever ACL reconstruction, it should be your own tissue. Now, in terms of quad tendons, I've actually been rehabbing about 3 or 4 at the moment, and they're doing brilliantly. They're all soccer players, and to me, a quads tendon repair makes sense in a soccer player because we know that hamstring is an important muscle for soccer players, and it's also a very important muscle to protect that ACL graft as well, to stop that anterior translation and provide a nice eccentric backing. And we also know soccer players have really high numbers of hamstring strains too. So if you're playing around with a hamstring graft in a soccer player, the graft might be fine, but then they might have a season full of hamstring strains if they're not careful, which is quite frustrating in itself. So look, for these guys to have quad tendon repairs, it makes a bit more sense because you're keeping that hamstring tissue nice and healthy. So you've got a better chance to keep them on the park. But also too, from a rehab point of view, what I've seen out of these guys has been fantastic. I was actually filming he's 10 months post-op. He's a 25-year-old soccer player, he's 10 months post-op. We're putting him through the Melbourne ACL Rehab Guide yesterday. We did the side hop test, which you guys might be familiar with if you've downloaded the guide. He punched out about 65 side hops in 30 seconds. Like, he was so zippy. I'm going to show the video later on this week. It was incredible. I've never seen a guy move so fast. And his healthy leg was 70. So he was just so zippy, and there was nothing wrong at all with his operated side. It's been really, really good all the way through rehab. So I'm a huge fan of the quads tendon, if I'm being honest. But look, graft really doesn't matter as long as your own tissue. So if you want to have a bone patella bone, go for it. If you want to have a hamstring, or if you often don't get the choice. It's often the surgeon's choice what you get. So maybe find a surgeon who deals mostly with hamstring grafts, patella tendon, quad tendons, as opposed to one that is exclusively using donor tissue or synthetic material.
Yeah, I think the surgeon that you go to, whatever they're most comfortable and confident with, and they've seen good outcomes with, that's what they're going to do. If you don't like what they're going to do, go get a second opinion from someone else.
Absolutely. It's your knee, it's your future knee health, and certainly the graft placement matters.
Oh yeah,
so where the graft is.
That's another rabbit hole.
Yeah, the angle. Yeah, exactly. So for people that are having primary ACL reconstructions, you'd want to see a surgeon that does a lot of them per year. We're talking in excess of 500 per year. You'd want to see someone who does at least 500 a year, even more.
Yeah, that's another thing. I think a lot of people don't really take that into consideration, but the bone tunnels, the size, the angle, all those things. I mean, there's a lot of physical therapists in the room, but if you're able to get the op report, or if you're able to talk to the surgeon and sort of learn what was the bone angle that they took, what was the size, what was the graft, that's going to sort of help you with determining, okay, well, like, can I expect maybe limited knee flexion down the road, limited knee extension, how much rotary stability are we going to get? That's taken rehab to the next level. But I think you made awesome points with the graft. At the end of the day, if it's your own tissue, you're just going to have a better outcome with your body accepting that tissue. Unfortunately, you and I talked about before we got on air, but we've had the unfortunate cases where people's grafts aren't taking if it's not their body's tissue. The quad tendons, I've seen 2 girls do really, really well with the quad tendon. And I know that there's more research coming out about it. And then also there's the whole idea of the repairs now, where they're just going in, they're trying to repair the ACL itself. I know that they're doing that out of Boston. I forget the exact surgeon's name, but who knows where, this ACL reconstruction or repair may be in the next decade.
Yeah, and I think that's the cool stuff where we talked about the blood flow restriction and how we're all sort of looking for this. We're all looking to cut corners through ACL rehab, and we're trying to speed things up and accelerate things, and that's fine. Like it'd be nice to turn an ACL reconstructed rehab into a lot longer than our current best practice of 9 months. Yeah, look, it'd be nice to get people back sooner than later. But I guess at the end of the day, if you elect to have synthetic material, if you look to have these repairs, if you're looking to do these extra things like blood flow restriction or those kind of things, it doesn't really it certainly doesn't take away from the high quality rehab that you still got to put in. And a high quality rehab really has to include jumping, landing, sport specific conditioning, and then a gradual progression through trainings and sport. And that all takes time. You can't just accept that you have surgery, you fluff your way through rehab for, maybe 3 to 6 months, and then turn up to first day preseason and expect your graft to survive or for you to perform, especially if your rehab quality's been really poor. I think that's the key message. Is as nice as it would be to go back at 6 months, if your rehab sucks, then you've only got yourself to blame if your quality isn't that great, or your graft fails, or your other side fails over the next 6 to 12 months too.
Yeah. All right, next question. Post-op, when do you want knee swelling to be going by? What are some of your favorite tips for patients to improve their knee swelling?
Yeah, that's a good one. There's many. Look, you certainly want the knee straight as soon as possible. That's the key one. And I'd like to see the knees dead straight consistently in the clinic. My clinical practice might be a little bit different to most in the States. I don't want to see a patient too frequently. And I work in an outpatient. I don't work in a hospital. I don't see patients day 1, day 2 post-op. I'm not that physiotherapist. I see the physio. I'm the physiotherapist that will see you in my clinic 2 weeks post-op. So often the people will be doing their physio-led exercises as they have their surgery. They'll see a physio in the hospital. The physio in the hospital will give them stuff to do, and they'll get discharged home. They'll do their exercises. So I'm really relying on that person then to do those physio exercises for the first 2 weeks before they come and see me. Now, a lot of those simple exercises are range of movement and exercises to try and keep the knee straight. So what I'd love to see is have that knee straight at 2 weeks and then consistently again at 4 weeks. So those week 2, week 3, week 4 visits, I want that knee consistently straight in zero knee extension at about the 4-week mark. That would be my ideal scenario. In terms of knee bending, I'm happy for the knee to get to about 100 to 110 degrees by week 2, week 3, week 4. No more than week 4. We know the knee bend will gradually come with time. We don't expect full knee flexion at all, really, in the first probably 3 to 6 months. There's often just a little bit of a lag behind the other leg in terms of flexion for a very long time. But as long as that person can bend to 110 degrees, then they can ride an exercise bike comfortably. Right? And I'm happy with that within the first month. But importantly, that knee's got to be dead straight for your quads to fire and for you to do some really important quad work to then set your rehab up in later weeks and months. One of my exercises is the passive knee extension, where you basically lie on your back with a foam roller at the end, or an edge of the couch where your heel's up on the foam roller. There's nothing underneath your knee, and you're just letting your knee hang and letting gravity do all that hard work for you. Now, that's going to be pretty tough and uncomfortable. I don't expect people to do it for minutes on end. It's going to be tough. You might only get 10-second rounds or 30-second rounds the first few weeks. That gets better and better with time.
Yeah, the first month, people don't like me. I want to tell them we need the knee straight.
Yeah.
Running weights. People are not happy. But at the end of the day, it's like...
No.
And I see some questions going in.
It's a tough love to have to show.
Yeah, no, people are very unhappy with me. Some questions rolling in.
As long as you do it with a smile, Craig. You have to do it with a smile, and people forgive you if you do it with a smile, mate.
Yeah. No, I just tell them like, you're gonna thank me in a month. Like you're gonna thank me so much.
Yeah,
And unfortunately, like some of the questions are coming in, like I think Mick can relate to it. I can definitely relate to it. People end up having swelling months after, or people are lacking
yeah,
extension, people are lacking flexion. So we definitely hear you. We don't see perfect
yeah.
people. I have some of the most complicated ACLs I've ever seen right now.
Mm,
Let's jump on to the next question because we're starting to get a lot of questions rolling in. Um,
yeah, yeah.
so Mick, what is the ideal frequency for ACLR rehab per week? What is your ideal frequency? I know mine.
Yeah, yeah. Look, and I think this is where the clinical practice certainly differs between Australia and America. And I had a student come and spend some time with me from Denmark just recently, and they were saying that they see post-operatively ACL reconstructed patients twice a week for 8 weeks, and pretty much doing passive therapy for 8 weeks. And I was like, wow, what a waste of time and money. Look, I see patients once a week for
Uh-huh.
the first from weeks 2 to weeks 4. So really only for probably 2 or 3 weeks, I'll only see them once a week. I'll give them a whole lot of home exercises to do, and I'll supervise them in the gym for that one session per week to make sure they're competent. If they're uncompetent or they're really struggling, I'll see them a second time in that week for some more supervision.
Yeah.
Um, but that's my clinical practice really for the first month. And then moving on after that, most people that I'm seeing at the moment, they're a bit older and a bit more mature as well. Like I was saying to you before off camera, I'm seeing a lot of people where my practice is. It's in the CBD in Melbourne. There's no schools around, and my hours are school hours. So I'm not going to get a whole lot of kids coming in to see me. So I'm seeing the 20 to 40-year-old demographic who are a bit sort of older. They're all already in the gym. They're a bit more mature, in that they take ownership of their injuries. Where a young teenage kid, they're probably not taking much ownership of their injury. They're getting mum and dad to drive them around and going and being forced in rehab and getting into an environment they're very uncomfortable with and don't want to be. So you probably need to see them more often than what I do. And certainly my patients, mine are much older and more mature. So look, from about week 6 onwards, I really start scale things back, and I start then working collaboratively with exercise professionals, because that relationship's really important. That for what I can't do in my time frame, that person needs to be doing a lot more work than that 20-minute, half an hour window that I can actually see them for. Once I've assessed the knee, I've only got probably 20 minutes to sort of actually go through the exercises and make sure they can do them well. Whereas an exercise professional's got a good hour block that they can do to make sure they're competent. So that's really that important relationship that I tend to strike up around about that 6 to 8 week mark. And then the people start seeing less and less of me and more of their S&C coach or their exercise professional. They come in and check in with me every 4 to 6 weeks, so I can measure their strength, measure their hop, measure all these kind of things, measure their swelling, make sure they're progressing through rehab. And then I send them back to their S&C coach again. Now that process continues for 9 months, 12 months until they go back to sport. So my clinical practice certainly differs to probably most of you guys out there.
Yeah. I think probably everyone in this.
How's it look for you?
Yeah, I was going to touch base on that. Just saying, it's definitely different for me. I think it's just because of most of the patients that I see, they don't have that strength coach readily available, or maybe they never had that relationship in the first place. It's like I have my CSCS, I have my PT license, and fortunately, a lot of the ACLs that I do see, Nick sort of touched on it. I do see a lot of teenagers or younger individuals in their 20s. And if they have good insurance, I'm seeing people for 9 months, maybe even up to a year. Or at the clinic that I work at, we sort of developed a way where people can continue to do rehab, do a strengthening and conditioning program outside of insurance. And yeah, for me, I think starting out, it all depends on the person, right? Because if you have an ACL reconstruction, you're working on it, you're taking care of that thing 7 days a week. It's your baby. If the person has a hard time being compliant, maybe I'm trying to see them 3 times a week. But for the most part, I'm probably seeing people twice a week, maybe 3 times a week.
Yeah.
And it's just a matter of what you put into it. If these teenagers invest their time into it and they end up doing better, and then they have to see me less and they're able to do more stuff on their own. Versus other people, it's like, hey, Craig, if I see you 3 times a week, then I know for a fact I'm going to be taking care of my knee 3 times a week, and being really good about my rehab. So totally case by case, and totally by insurance. Like, man, I have some people that get approved for 5 sessions, and then that's it. And then I have to justify another 5 sessions. And it's like, are you joking?
Yeah.
This person just had ACL surgery, and you're only going to give them 5 sessions? Like, you're joking,
Yeah,
right?
that sucks.
To get back to skateboarding.
Yeah.
So it's
Yeah.
case by case, and I think every single person in this room can relate to that.
Yeah. That's a tough one.
Yeah, and it's really unfortunate, but I think at the end of the day, ultimate goal of this webinar was to educate people that join this webinar, and for them to educate their patients, to educate the public, so that people are getting good quality care, because it's a great resource.
Yeah.
You can, I mean, the internet today in general, like if you're a go-getter, you want to take care of your knee, you can find every single resource on the internet to take care of your knee. It's just a matter of if you want to put time and effort into it.
Yep, absolutely.
All right, here's like always the hot debate question. Open connect chain knee extension. When do you start?
Yeah.
Versus 90 to 40 versus full range of motion, and why?
Yeah, I love this. I love this because I'm really passionate about this.
Yeah.
As weird as that sounds, like when I was a new grad, I was so fearful of knee extensions and open kinetic chain because it was drilled into us from very early stages in university. And this goes back to 2006 to 2010 when I was studying. And then for the next couple of years as a new grad, I was still scared of open kinetic chain. I refused to use them. And it's only been the last probably 3 or 4 years that I've actually stopped and thought, hey, hang on, like if someone's going back to soccer and they're kicking a ball in an open kinetic chain way, why are we not getting them to do that stuff in their rehab? Or, like it just doesn't make sense. So I started to read more about it and I started to become less fearful. Now, there's been some really good publications recently trying to dispel this myth that if you do open kinetic chain exercises, you'll increase the laxity of the ACL. Now, what the research will show us is if you introduce them from as early as 4 weeks in a reduced range of movement, and so this reduced range of movement is 40 to 90 degrees range of movement. If you stick to that range of movement and stay at that time, so between weeks 4 to week 12, and if you stay to that reduced range of movement, you won't increase the ACL laxity at a later date when they follow up at 6 months, 12 months down the track. And importantly, you're strengthening the crap out of the quads, okay? What we typically see is when you're trying to do a squat, when you're trying to do a lunge, when you're trying to do a leg press, on an ACL reconstructed knee, in that sort of first 3 to 5 month window, you're going to shift the load to the other side or up to the glutes, and you're going to miss the quad because you're going to be fearful of that knee. And often that's due to lack of strength or lack of, confidence and all these kind of things. So what knee extensions do, or open kinetic chain exercises do, is that increase that strength and increase that confidence to allow you to bend and straighten the knee. Now, full range of movement, so from 0 to 90, can be implemented safely at 12 weeks through to whenever. And that once again, the research will say that you won't increase the laxity at the graft at 6 months and 12 months and even longer down the track. So we know we can do these things safely. And don't for a second think that you're not increasing the stress or strain through the ACL through a closed kinetic chain exercise too. People often forget about that. When you're doing a squat, when you're doing a lunge, when you're doing a leg press, you're straining the ACL. So there's often this fear that we're going to strain the ACL. It's like, of course you're going to strain the ACL, but sometimes strain's a good thing. But it's just how much strain you put through the ACL is really important. So in the first 6 weeks, but what makes me sleep well at night is that I basically keep reduced range of movement exercises, so 40 to 90 from about 4 to 6 weeks post-op, depending on the patient. I'll do reduced range of movement up until 12 weeks, and then from 12 weeks onwards, I'll let them go unsupervised in a gym to do full range open kinetic chain exercises. But before 12 weeks, I don't get the person, if I can't see them do it, and if they've got really poor body awareness, they don't know where their knee angles are, I won't get them to do them unsupervised. And I think that's an important thing to know. Don't think that your patient knows where 40 degrees is and 90 degrees is. And I think that's one thing that is really a key message that I say to my patients. If you can't block the range of movement on your knee extension in the gym, then don't worry about it. We'll get your quads back eventually. Or alternatively, come and see me once a week for the next 8 weeks if you want to do that and spend the money to do that. Alternatively, let's wait till 12 weeks and do full range unsupervised. It's up to you. So I guess when you bring them in is completely up to you and what makes you sleep well at night.
Exactly. And I think there's at least one article out there. I can't recall the name of it, but they looked at it and it was like, all right, open chain, 90 to 40, ended up not increasing laxity of the graph, wasn't detrimental to the graph, but also comparing it to doing closed chain strictly for the first 3 months, it didn't have an additional beneficial effect. So if you're smart about it, you're not going to make it worse, but also at the same time know that it's not going to be superior to doing closed chain. You're going to want to do both.
Yeah.
And then
exactly. So you want to do both. Exactly. That's the thing, and that's where a lot of when I sort of post some of these open kinetic chain videos, it's often get some feedback saying, well, what about squats? What about lunges? It's like, well, of course, do those things too. It's got to be a comprehensive program where you're doing a mix of open kinetic chain and you're doing a mix of closed chain. But importantly, the biomechanical studies on squats will show that at 3 months, an ACL reconstructed patient will shift to their unoperated leg. So they'll be fearful when they do a squat. At 5 months, they'll keep the weight even, but they'll still use more of that operated side glute, and they won't be using that quad enough. So that's where you've got to strengthen the quads. And I reckon that's impacting on people's future problems when you're doing only closed kinetic chain exercise. If you've got the mix of open kinetic chain and closed chain, I reckon there's going to be some success there.
Yeah, and I think we'll touch base on it earlier, other ways to really beef up that quad. There's been questions coming in about BFR, and I can sort of touch on what I'm doing with the open chain stuff using BFR. But let's keep running some questions. All right, return to running. What's your return to running looks like? So I know for everyone here, if you look at the offers, you're going to find the Melbourne ACL Rehabilitation Guide 2.0. And I'm sure that probably there's a lot of stuff that comes out of that testing that you use, but maybe you can elaborate in general or maybe anything else that you include, because I'm including one test that I really like and use to sort of look at quad endurance.
Yep. So look, the reason why and this is what we're really proud about with the Melbourne ACL Rehab Guide is that we've devised this program that sort of filled in a few gaps along the way. So we've looked at previous protocols where it's been basically immediate post-op. We want this criteria, 1, 2, 3, return back to training, meet criteria 1, 2, 3, and then return back to sport. There wasn't that sort of test to say, when can a person run? And that's where we've filled in the gap. But also importantly, we've also filled in the gap with clinical friendly examinations or strength tests to see if someone's ready to run. You don't need fancy handheld dynamometry. You don't need force plates. You don't need 3D equipment. You don't need anything basically but a bench to sit to stand off. Maybe a camera phone to look for form. That's the beauty of some of these tests that we've got in there, and particularly the return to running test. Now, if you look at the literature, there's a huge gap in when people should be tested and found ready to return back to sport. And of over 200 papers, only 1 in 5 added something other than time. Now, the most common time point to allow people to return back to sport was 3 months. And that makes sense because the revascularization process of the knee has run its course, and now the ligament's strong enough to deal with the impact of running. But you need really healthy, strong quads and lower limb muscles to run. Otherwise, the knee's going to flare up. You're going to get a joint synovitis. You're going to get PFJ pain or ITB pain or whatever it is. So we've got to make sure the rest of that muscle unit's strong. So our criteria for return to sport, return to running, is probably wait at least 3 months from a time point of view, because we know also bone bruises that happened at the time of the injury will probably be still lingering around, which might make you a bit sore. So 3 months down the track, things bone-wise and biologically should have settled down. We also want to make sure your lower limb quality is really good. So we ask people to do 5 good quality single leg squats. We also want 10 single leg sit to stands from a 90-degree knee angle. We also want 20 single leg hamstring bridges off a chair, so off a chair bridge. We want 15 single leg heel raises. We want a 30-second side bridge, and we also want a 30-second single leg stand. So we're really asking these really simple, easy to do strength tests are ticked off and comparable to the other side. When we say comparable to the other side, we want the other side to be no more than 15% stronger or more in terms of numbers than your operated leg before you go off running. Anywhere between the 3 to 5 month mark, or even longer for some people. You know, every person runs their own race in rehab. Some people might not be running because it takes them 6 months just to get their basic strength qualities back.
Yep.
So you run when you're ready to run.
I like it.
But pass those criteria.
Yeah, I sort of I've been exposed to what some other clinicians are using, and there's some people that, you know, if you've ever heard of the VAIL, like return to sport test, there's a test in there where they look at like single leg squatting, 3 sets of like a minute. They're adding like a cable, and they're looking for like very, very perfect form. I've sort of modified that, and now like the other day I did to my patient, and it's mean. I need to put myself through it. I don't even know if I could truly do it, but 3 sets of single leg squats. Depth, I'm really not too worried about. Like, I let them be sort of self-selected. At least they're going down. They're bending at their knee. I think parallel is pretty darn tough. And if you look at just the mechanics of running, we're not getting parallel. So self-selected, I'm seeing that the person can do 3 sets of single leg squats with a 30-second break in between. And he did 2 minutes and 45 seconds. So I was really impressed. I just think that we're looking at it from an endurance standpoint. You know, running, it's just repetitive bounding and single leg squatting. So.
Yep, absolutely. That's a good test. I might use that one.
Put yourself through it, and check yourself, because I did it to him. And
I had to run to catch the tram. I had to run for about 3 minutes. I struggled. So I've got 2 young kids and a dog. I'm a walker these days. I'm not a high level athlete. So
it was fun because I made him do it, and then he's like, "All right, now your turn." He's like, "There's no shot that you can make me do this, and then you're not going to do it." I tried doing it. And, after 2 minutes, I was like, "All right, I need to use the restroom." Copped out.
Yeah. Cool.
All right, return to sport. 9 or 12 months timeline, should that even be a thing, or should we move away from the numbers?
Yeah, this is really cool, and it's the research is really changing, and it's changed quite a lot in the last 12 months to 2 years in particular. So this kind of magic figure of returning back to sport at 6 months or 9 months or 12 months, time alone is a poor indicator to future ACL success and graft survival. What we're seeing from one paper in particular, that if we're going to use a time point, 9 months post-op should be that time point. What that research showed, that if you waited 9 months, your risk of re-injury was significantly less than if you came back earlier than 9 months. And that risk basically was 50% per month before 9 months. So, and then at 9 months, 10 months, 11 months, it all leveled out. So if you go back to sport under 9 months, it carries a really significant risk. And look, for some people, that risk is versus reward. So it's a risk versus reward thing. Like, we had a guy here in the AFL, our major footy code here in Australia. He returned back to high level AFL, so the best code here in Australia and the best level, at 6 months post-op. He injured his ACL in March this year, and he was back playing finals footy 2 weeks ago at 6 months. Now, that's a risk versus reward thing. Like, he passed all the criteria by all accounts. He wouldn't get cleared medically if he wasn't fit or strong enough to compete. And now he's played 2 games and he's played really, really well. So it's a risk versus reward thing. For the non-professionals, I don't advocate, if you're getting paid to play if you're not getting paid to play a sport, you're not getting paid to go to physiotherapy, you're not getting paid to go to the doctor and the surgeon, all these kind of things like professional athletes are. I don't advocate for a return to sport earlier than 12 months. Because I know that the quality of the rehab won't be as good as that professional athlete. So it's return back to sport for my non-professional cohorts at no earlier than 12 months, plus pass all the criteria that we set down in the Melbourne ACL Rehab Guide. Now, there'll be occasionally people who are just sub-elite who will be pushing hard, who will be trying to put their hand up for a semi-professional gig. Like, I've got a couple of guys who get paid, a couple of $100 to play soccer. Now, those guys are in a good environment where they train regularly, they play regularly, they've got good S&C coaches. I'll be a little bit more lenient with them. If they get to 9 months and then pass the criteria, I'll let them go. But someone who's, 20, 25, who just mucks around at amateur level footy, I won't let them go back to sport. I won't advocate anyway. They can go back. It's up to them. At the end of the day, it's their decision. But I won't give them the green light from my point of view until they've reached 12 months and then also passed all that criteria that we set.
Yeah, and I can't reiterate that.
Probably very different than America. I know there's a quest to be bigger, faster, fitter, stronger, and get back to sports sooner and be like Adrian Patterson and all that kind of stuff. Like, I know the American system is probably very different here to Australia, but for me, what makes me sleep well at night is certainly wait at least 9 months and pass the criteria. And the same should be for you guys too.
Yeah, I mean, I think Adrian Peterson screwed us all as physical therapists because now
I heard that. I'm not that familiar with NFL, but I heard he's made it very difficult for all you guys over there now.
He's a freak, and now it just makes our life that much harder as physical therapists because that's the story that you hear if you tear your ACL, especially if you know football, you know him. So then everyone thinks that they're going to get back to playing sport in 6 months. So as cool as that story is, now it's completely skewed the public's view of getting back to a sport. And I can't reiterate enough the criterion. So I myself, I'm a firm believer in you got to pass criteria as well as the timeline. I do all the Melbourne, return to sport testing. It is so comprehensive, like Mick, and then another guy's name, I always forget.
Randall Cooper.
You and Randall, you guys work so hard, and that program is so comprehensive. Like, I use it every single time. The subjective is so important.
Yeah, the subjective questionnaires too is something we certainly added in. But what I like from is quite clear, because we've added in that fatigue protocol now is the one that the original ACL rehab guide that Randall made in 2013. We tweaked it to bring it up to 2018 just recently, if you're unfamiliar with it. But we've certainly added a few more elements, and one of them is that fatigue protocol. So we want you to do the strength and hop tests in a fresh state, but then go do a training session and really get fatigued and then try and punch out the same numbers. Now, you guys did a cracking video just recently where your guy passed all the criteria, then you fatigued the crap out of him and he came nowhere close in passing the criteria. Now, we've got to be sending our patients back to the worst case scenario. We have to have them prepared through rehab to cope with the demands of sport. So an ACL injury is more likely, for what I've seen clinically, it's more likely to happen at the start of a game when they're ineffectively warmed up, or it's going to happen at the end of the first half or the end of the second half when fatigue starts creeping in. Okay, so we want to make sure that they can resist fatigue and they're able to get through a game. And so that only happens through rehab and actually training hard. So that's a really important criteria, is that you pass the test again when you're fatigued, because that tells us, what's your quality like then.
Yeah, that's my favorite part, because that guy that I shared videos of, he's a stud. So strong, stronger than me, like a complete stud. But then fatigued him out, and he's like, dude, I have nothing left in the gas tank on this side.
Yeah.
He surprised himself. He surprised me, because I thought that he would do better. All right, with the time that we have left, I think we just do round.
I've got about 5 minutes to go, Craig, before I have to probably go and do some bad duties.
We'll do round robin. Why don't we do this? Let's have you scroll down. You look at the questions that you feel comfortable with answering. Anything BFR, I can totally cover and stay on to do it. But the stuff that you would like to answer, just jump into it. Let's try to get the answers out in like 30, 60 seconds, because a handful of questions came pouring in. So I can cover Nick. The question from John, maybe if you want to touch base on that.
Where's John?
If you scroll down to the bottom, he's right above Nick. So I have an ortho
Do you have
specialist.
this criteria?
Here, I'll read it off. So, question from John. I have an ortho specialist that is happy for his clients to do an hour of cycling 3 to 5 times a week for 9 months and gets great return the sports results. He swears this is the only rehab his clients need. Thoughts on this?
Wow. If they're a cyclist, yeah, go for it. If you're gonna ride in the Tour de France or do some cycling work, that is great rehab for a cyclist. Not not ideal, not ideal for someone who's playing running based team based sport. That's not a great. He's obviously got some kind of selection bias there that he's seeing. Look, yeah, my thoughts and feelings on that is cycling for 3 times a week for 9 months. Look, it's going to make the quad strong. It's going to make the person fit and healthy. Whether or not that prepares that person for a change of direction sport like NFL, like basketball, like soccer, that is not enough.
Yeah. Shannon.
You probably need to check out my ACL rehab guide.
Yeah. Question from, well, not necessarily a question, but a statement from Shannon. She had her ACL reconstructed.
I know Shannon. Hi, Shannon.
She went into surgery.
Shannon's email.
Went into surgery with a non-functioning leg too soon after injury. Prehab was never mentioned. Big problem. Set me up for all sorts of delays. Shannon, we feel your pain. We feel the struggle. We have patients that see both of us that have this same thing. That's why we're doing this questionnaire. It's like we got to educate people. We got to educate the world that you have to do stuff before you get surgery done. It's like the fact that I really hope that every single surgeon is recommending people to do something. I actually created a brochure that I'm handing out to the surgeons that refer patients to us because it's going to make their outcomes better. It's going to make the outcomes be better. But it's like if a surgeon wants better outcomes, it would be the smartest decision to refer people to pre-op.
Look, and look, I've emailed, and Shannon's emailed me a couple of times, and the interesting thing about Shannon was that she also had a bit of a misdiagnosis, and that's not in terms of ACL injuries, but for secondary knee pain. And that's another thing to consider too, is that often, ACL reconstructed patient, they often do get that side effect of patellofemoral joint pain. And that's going to be the most common secondary injury that you'll get through rehab. It's not going to be patellar tendinopathy, or it's not going to be anything ITB pain or anything like that. So if you're getting a diagnosis after your rehab, you're getting a sore knee, and someone's telling you it's a tendonitis, tell them that, well, it's not your place to say, but certainly don't be thinking a tendonitis after ACL reconstruction. Thinking patellofemoral joint pain, because you only get a tendonitis with repetitive jumping and landing. And they think basketballers, think volleyballers, they get patellar tendinopathy. If you're 6 months in rehab, you haven't been jumping yet, you got knee pain, 9 times out of 10, it's going to be patellofemoral joint pain. Now, one way to overcome that is by isolating the quads or strengthening the glutes, strengthening the hamstrings. You've got to do these muscles in isolation, and in particular, it has to be the quads. And that's where open kinetic chain exercise is an absolute must, particularly those that are getting patellofemoral joint pain. So, it's the ranges and the loads that you lift are the key thing. So open kinetic chain, PFJ loves 45 to 90 degrees. In closed kinetic chain, it loves 0 to 45. So it's got to be a mix of the two, okay? The help of blood flow restriction, I don't personally use it, but I know the evidence supports blood flow restriction for PFJ pain patients. So for you guys that use blood flow restriction, start using it with your PFJ pain patients, even those with the coexisting ACL reconstruction. So there's lots of things out there, because a lot of people will have PFJ pain throughout their ACL rehab. So that's a very common scenario that we see. So from a clinical point of view, you need to listen to your patient. And if they're struggling through rehab, they can't tick their rehab off because of that kneecap pain, then we've got to basically scale everything back and get those quads right and then reload them again.
Yeah, I can touch on that later. Really exciting and cool evidence to show BFR was It was super helpful and awesome with people with patellofemoral pain syndrome.
Yeah.
By Nicholas.
Okay, I might have to go, mate.
Yeah.
I can hear the kids upstairs, so I'll have to sign out. But
No
for everyone that's joined in on today, if I haven't had a chance to answer some of the questions that you may have had, I've left my email in the chat. What I'll also do too, for those that have joined, I'll just want to give a special offer. I've got my link to the Melbourne ACL Rehab Guide there in the offers, but I've also got some online tutorials that may answer some of your questions as well. And I'll leave the link to that in the chat. And as a special offer today, I'll go on later. I'll let you guys get access to that at a discounted rate. So jump onto my website, mickhughes.physio. Click on the ACL lecture button. I'll leave the link down here, and you can get access to my online tutorials too, which might be helpful for you guys as well. Might answer some of your questions that you may have. So they're your two options. So sorry I can't sort of answer all of them, but by all means, get on top of that today.
Yeah, it's like 3.5 hours worth, right, Mick?
Yeah, about 2.5 hours, but there's three separate lectures there.
No, it's good. All right, Mick, thank you so much. I'm going to stay on. I'll answer the rest of these questions, and then I'll connect with you.
No worries. I'm just going to type in that link for everyone to jump on. There, it's in the feed, and then click on ACL lecture button, and away you go. Cool.
Awesome. All right, Mick. Thanks for joining us.
Thanks very much for your time, mate. I'll talk to you later. Thanks, guys, for everyone for joining in today. I've really enjoyed discussing ACLs. I'm on a Facebook Live later on tonight too, if you guys are interested in tuning in. I think it's about midnight your time, so that might not be too helpful for you guys, but you can get it on my Facebook page later tomorrow if it's too late for you guys to watch.
Awesome. All right, Mick, take care.
Cheers, Craig. See you, mate.
All right, so I'm going to continue answering questions.